Hi everyone. In this session, we'll be talking about indications for invasive mechanical ventilation. And when we say invasive, it basically means there is placement of endotracheal tube through the trachea to allow the patient to be connected to the mechanical ventilator. So one indication is failure of non-invasive ventilator, or somebody who has failed what we call high flow nasal cannula. An example of non-invasive ventilator could be things like CPAP, which is continuous positive airway pressure, or it could bypass any of this. Number two is somebody who has failure to oxygenate. And this could be evidenced by what we call hypoxemia. Hypoxemia is basically decreasing partial pressure of oxygen in the plasma. So if somebody has failure to oxygenate, that could be another indication. And the things that could cause failure to oxygenate include maybe progressive pneumonia, pulmonary edema, acute respiratory distress syndrome, or somebody who have pulmonary emboli. The third is failure to ventilate. Like we mentioned yesterday, ventilation is getting rid of your carbon dioxide. And if a patient has failure to ventilate, we can see their carbon dioxide is going to start increasing in the blood. So we can see increase in partial pressure of carbon dioxide. And this could be related to things like obstructive lung disease, like acute exacerbation of COPD, asthma exacerbation. It could be related to drug overdose, like somebody overdose on opioid, because opioid could decrease the respiratory drive, and that could make patients start hypoventilating. And it could be related to neuromuscular disease, for instance, like Guillain-Barré, myasthenia gravis. Any of those conditions could affect the diaphragm, and that could affect the ability of the patient to ventilate. The next indication is airway protection. Airway protection. So this could be related to somebody who is unconscious, or somebody who has altered mentation. So in those patients, because they can't protect their airway because they're unconscious, you might want to put them on a mechanical ventilator. It could also be somebody who's having severe upper GI bleed. So somebody who's having upper GI bleeding and they are vomiting, because of risk of aspiration, you might also electively intubate those patients and place them on mechanical ventilator. Another indication for airway protection could also be somebody who's having anaphylaxis reaction. Somebody's having anaphylaxis. Because sometimes with some extreme form of anaphylaxis, it could involve the breathing pipe, including the vocal cord, and that might make intubation to be difficult. So in those patients, you might electively intubate them in order to protect their airway. The next indication is hemodynamic instability. Hemodynamic instability could be a patient who has shock. Patient that's in shock with increased work of breathing. Then this patient that is having in shock with increased work of breathing and they're tachypneic, a good amount of their cardiac output will be going towards the respiratory muscles and the muscles that help with respiration. And so that means the blood that's supposed to be going to the organs that are affected in their shock will be shunted towards their muscle of respiration. And in order to be able to mitigate that, we can also electively intubate those patients. In that way, the ventilator will be breathing for them, and that will decrease the amount of blood or the amount of oxygen that's being shunted to their respiratory muscle, and thereby preserving those oxygen, preserving those blood for other organs in the body that really needs them. The other one is also somebody who has unstable arrhythmia. So this will also be another indication because unstable arrhythmia could lead to hemodynamic instability, for instance, like ventricular tachycardia, VFib, all those could lead to hemodynamic instability, and that also warrants invasive mechanical ventilation initiation. And the last reason is increased work of breathing. So increased work of breathing. Any of these above that we've talked about could lead to increased work of breathing. And in addition to that, somebody who has severe metabolic acidosis, like in the case of DKA, diabetic ketoacidosis, this will increase the work of breathing, and as a result of that, this might be an indication for mechanical ventilation. So having said that, so how does this translate into the parameters that we're going to place the patient on, right? So the way I normally approach this, different types of different way, but the way I normally approach this, I divide this indication into four because that will help me my thought process when I'm thinking about what type of setting I'm going to start with, and we have to prepare for this. So I divide it into this patient into four categories. One are the obstructive type, the obstructive pathology. The under obstructive pathology, that's where we have the COPD exacerbation, asthma exacerbation, airway obstruction. The second group are the restrictive pathology. And the under restrictive pathology is going to be where we have our acute respiratory distress syndrome, anything that will affect the compliance of the lung. Acute respiratory distress syndrome, someone who have underlying interstitial lung disease, or someone who is morbidly obese, right? That's affecting the compliance of the lungs. Number three is what I refer to as the hyperventilating group. What I mean by hyperventilating group, so these are the patients that they have very increased work of breathing. They are hyperventilating because of the underlying disease that is going on. For instance, someone who has severe metabolic acidosis, maybe because as a result of shock or as a result of diabetic ketoacidosis, right? So any of these will make the patient hyperventilating. So those patients, they are taking a lot of tidal volume and they're also breathing very fast. So I call them the hyperventilating group. And the last group are just the others. These are patients that we electively intubated for airway protection, right? So they fall under this airway protection. They fall under this category, right? Or somebody who have things like maybe neuromuscular disease and they're having issues with ventilation, I could also put them under this category. Or somebody who's over-sedated, like somebody who have drug overdose, they could also fall under that category, under others. So the reason why I divide them into these four main categories, it helps me to think about the initial setting, because the initial setting is very important for the purpose of allowing the patient to be synchronous with the vent and addressing the underlying issue while we're intubating them. So with the obstructive pathology, like we said yesterday, for oxygenation, right, we said that when we're initiating mechanical ventilation, we divide them into two: oxygenation and ventilation. So we have to set what's going to up on the ventilator with oxygenation and what's going to up with ventilation. So in terms of oxygenation, like we said yesterday, right, we're going to set our FiO2, and like we said, it could be anywhere from 21%, it's usually the least, to 100%. We're going to set the PEEP, and the PEEP usually start from 5, and it could go anywhere to as higher than that, right? So in patient who have obstructive pathology, I can only start from 5, but sometimes this patient might benefit from a little bit additional PEEP, because the PEEP, like we said yesterday, is the pressure in the lung that keeps the alveoli open at the end of expiration. So they might need a higher PEEP to keep their airway open, so as to allow them to easily exhale, right? Because with obstructive pathology, their issue is problem with exhalation. So keeping the airway open at the end of expiration will help them, and at the same time, it can also help them to decrease their work of breathing. So most of the time, I might probably start from 8 and 5, and sometimes I can go up to like 8, right? To start with. And like we mentioned, with PEEP, we always have to make sure they're not developing intrinsic PEEP, right? Because that will also worsen their hemodynamic status. Under ventilation, so things that work with ventilation, one, we're going to set the respiratory rates. In someone who have obstructive pathology, you always want to keep their respiratory rates on the low side, right? Maybe somewhere between 10 to like maybe 14, right? And the reason being because you want to give these patients enough time for exhalation, right? Because the lower you set their rates, the more time they have to have for exhalation. Because if you set their rates really high, they are not going to have enough time for exhalation, and they can start retaining a lot of gas, and that will increase their intrinsic PEEP, and that will lead to hemodynamic instability. So because I will be setting the rates on the lower side, I tend to put these patients on the higher end of tidal volume. Remember, like we said yesterday, we know that 6.6 per kg of ID body weight to 8.60 per kg is considered safe, right? So in this patient, because I'm setting their rate on the lower end, I normally set their tidal volume on the higher end. So I put the tidal volume at 8.60 per kg of their ID body weight. The next one is the restrictive pathology. So with the restrictive pathology, so for oxygenation, so depending on how bad their hypoxemia is before intubation, their FiO2 could be anywhere from 21% to 100%. And for the PEEP, same thing, similar principle, depending on how bad their hypoxemia is. If it's somebody that have a very bad ARDS, right, acute respiratory distress syndrome, they might need a higher PEEP, right? So depending on which ladder you want to go with. So depending on how bad the hypoxemia is, it could be anywhere from 5 to 24, right? In terms of the ventilation aspect, so in ventilation, in patients who have restrictive pathology, remember, this is a compliance problem. So because it's a compliance problem, you may not be able to put a lot of tidal volume in their lungs, because if you put a lot of tidal volume, that will increase the pressure, that will cause further injury to the lungs. So in this patient with restrictive pathology, I tend to go towards the lower end of the tidal volume. So I usually set their tidal volume to 6 per kg of the ID body weight. And then their respiratory rates, because I'm giving them a lower tidal volume, I tend to keep the respiratory rate on the higher side so as to compensate for this, compensate for the lower tidal volume, so as to optimize their ventilation. So anywhere from 20 and above. Sometimes you can go all the way to 30 or even 35. But like I said yesterday, they don't want to go beyond 35 because of risk of decreasing the amount of time they have to have for exhalation, because they can start developing intrinsic PEEP, which you have to monitor for. The next is the hyperventilating group. So similar principle for the oxygenation, things that to work with oxygenation. So the FiO2, same thing, depending on how bad the hypoxemia is, will be anywhere from 21% to 100%. And then most of the time, these patients, they usually require the minimum amount of PEEP, so we can set their PEEP at 5, depending on how bad their hypoxemia is. And then for what's going to work with ventilation, for these patients, I tend to keep them on because remember, before even intubating these patients they are hyperventilating, so they are breathing really fast and they are taking big tidal volume, right? So in these patients, I tend to put the respiratory rates on the higher side, usually close to 30, depending on what they're doing before the intubation, and the tidal volume. I also tend to go on the higher side because I'm trying to mimic what they are doing before the intubation. So I tend to give them higher tidal volume, 8 cc per kg of ID body weight, right? And then for instance, the reason for this, for instance, if you have a patient who have diabetic ketoacidosis, let's say the pH was 7.1 before intubation, and their PaCO2, let's say it's like 21, right? And their bicarb, let's say it's like 5. And this is just an example, right? So this patient, let's say this patient is breathing like in the 30s or in the 40s, and they're taking a huge tidal volume even before intubation. So if you decided to intubate this patient, right, and remember with intubation you paralyze them and you put them on sedation so that they can tolerate the mechanical to minimize vent desynchrony. Guess what will happen, right? Because you've taken away their respiratory drive by paralyzing them, this carbon dioxide, right, is going to start going, it's going to go up, right? Their partial pressure of carbon dioxide is going to go up, and as a result of that, that would decrease their pH, right? So the pH will go to really low, below 7, right? Which might not be compatible with life, right? And the only thing that the body care about is the pH. That's the only thing the body care about, right? So that's why sometimes there are some school of thoughts that say if the pH is less than 7.2 and they're going to intubate them, sometimes they give them sodium bicarbonate to be able to raise up their pH to prevent it from falling during intubation. Although there's another school of thought that will argue against it, that will say that if you give them sodium bicarb, the sodium bicarb is being converted to carbon dioxide, right? But regardless, you're going to put them on the ventilator, and even if carbon dioxide is being produced, you're going to optimize their ventilation to be able to lower their carbon dioxide, right? And giving them that bicarb will prevent their pH from going really low, and prevent it from cooling them after intubation, right? And then the last group is this the other, which include the airway protection and patient who have neuromuscular disease. So under this last group, the oxygenation. So most of the time, based on how much oxygen they're on before intubation. So if it's somebody that was on maybe like 2 liters of nasal cannula before intubation, right? So if you multiply 2 by 3, that's 6 plus 21. That's like 27. So this patient might not need more than maybe 30 or 35% FiO2 if I'm to set their FiO2, right? And also PEEP, most of the time they just require a minimum amount of PEEP. And in terms of ventilation, so similar thing, this patient most of the time they don't have any underlying lung disease, right? So you can always keep their respiratory rates between the normal limits between 14 to 20, and we can keep their tidal volume between the lung protective between 6 cc per kg of antibody weight and 8 cc per kg of antibody weight. Most of the time, I can put them on 7 to 8 cc per kg of antibody. The last thing I want to talk about before we leave is, before I close this session, is back to the obstructive pathology. So the other thing you can also do on the ventilator to help this patient with obstructive pathology, like for instance, a patient with COPD exacerbation or asthma exacerbation, is to increase their inspiratory flow rate. So by increasing the inspiratory flow rate on the ventilator, that will actually help you that will decrease the time of inspiration, and that will increase the time that is spent in expiration, like exhalation. Because remember, this is an obstructive pathology, so you want to give them more time with exhalation. So for instance, let's say as you are increasing the inspiratory flow rate, you're actually going to see the I to E ratio going up. So let's say it was initially 1 to 2. When you go up on the inspiratory flow rate, you can see that number going from 1 to maybe 3 or to 4, right? So that means they're going to be spending more time, right, during exhalation, right? So this is how I think about my patients, especially during the period of when to put them on mechanical ventilator, right? And if you have not watched the previous session, I strongly encourage that you watch it. That will give you a good background to how we come up with most of these figures. And I'd also love to know your thoughts about how you approach initiation of mechanical ventilator in your own setting. Thank you guys for watching.